Assalamu alaikum. Hi, my name is Dr. Mahmoud Mandoor. I'm an associate professor of otorhinolaryngology at Tanta University, Egypt. Today we will talk about intraoperative monitoring in cochlear implantation. Intraoperative monitoring during cochlear implant surgery is a tool to assess the integrity and proper function of the device. Also, it may give us an idea about the percentage of surviving spiral ganglion, which logically has an impact on the functional outcome after cochlear implantation. Also, it may be used to assess the progress of array introduction inside the cochlea and also to assure us about the proper placement of the electrode inside the scala tympani of the cochlea or inside the cochlea in general. Moreover, this intraoperative testing may provide us with a preliminary tool that may help audiologists in subsequent eye mapping later on, especially in difficult patients to deal with. What are the types of intraoperative monitoring? We have mainly two types: electrophysiological measurement and imaging. Electrophysiological measurement include impedance, electrically evoked combined action potential, or ECAP, which is the most popular form, electrical auditory brainstem response, and electrical stability reflex threshold, electrocochleography, and what's called spread of excitation. Imaging include, of course, the mobile plane X-ray, fluoroscopy, and intraoperative CT. Let's begin with intraoperative electrophysiological test. Impedance. What is impedance? Impedance is a method to measure the resistance to the current flow from the electrode of the electrode array or of the device to the surrounding tissue. So, impedance may be used as a method to test the physical integrity of the electrode itself. In other words, to make sure that there is no too much force or squeezing on the electrode that may damage the wire. So we can, if impedance is okay, now we are sure that the physical integrity of the wire and of the electrode is preserved. Number two is to test the status of electrode tissue interface. In other words, is to test the flow of the current from the electrode to the surrounding tissue. This is an example of the shape of the impedance when the technician or when the engineer make the intraoperative testing on the software of the company. As we can see here, this is what we call low impedance. This is a perfect result. Low impedance means that the electrode is in contact with a media which with an excellent or with very good electric conduction, which is most probably in such a case the perilymph. So now I can make sure that all the electrodes are in, all the electrodes are in contact with fluid or with perilymph. If we have high impedance, for example, like in such case, high impedance means that the electrode might be in contact with a tissue with low fluid content, relatively low fluid content. For example, if there is a blood clot on the electrode, if there is some sort of debris on the electrode, or if in the basal electrode and I'm making too much insertion of the muscle seal around the basal part of the electrode. So the basal electrode might be in contact with such tissue or with the muscle, and this may be also responsible for the high impedance. So if low impedance, this is the excellent result. This means that my electrodes in contact with fluid media. High impedance means that still the electrode inside the cochlea or might be inside the cochlea, but it's in contact with some sort of soft tissue or with muscles or with blood clot. But if the electrode is in contact with air, for example, if there is a large air bubble on the electrode or the electrodes, basal electrodes are completely outside the cochlea, then we will have what we call open circuit. This means that there is no current flow from the electrode to the surrounding tissue. There is a space around the electrode. There is an air around the electrode. Also, if two electrodes are in contact with each other, they will give us what we call short circuit. Okay, so we have an open circuit if the electrode is not in contact with the tissue at all, around air or outside the cochlea. Short circuit in the case of teeth fold over or all the two electrodes are in contact with each other. Now let's talk about ECAP. What is the basics behind the ECAP? Here, after insertion of the electrode, as we all know that the electrode now is around the modulus, around the spiral ganglion. Okay, so this is the electrode around the spiral ganglion. If we give an electric current to one electrode like that, this electric current will cause direct stimulation of the spiral ganglion, the dendrites of the spiral ganglion, the cell bodies of the spiral ganglion, and the axons of the spiral ganglion. This stimulation will make a depolarization at the neural membrane of the ganglion. This depolarization will generate an action potential. This action potential can be captured by an adjacent, not immediately adjacent electrode, but after one electrode, then take the other one of the electrode. For example, if I give the current at 5 or 5th electrode, so I can capture the ECAP from the 7th electrode or from the 3rd electrode, not the immediately adjacent electrode. Now, when I captured the ECAP from the other electrode, I will have this picture. This will represent the ECAP of the measured action potential. Okay, if we look more closer at this ECAP, we will find that it has a characteristic pattern or a formulation. It will have what we call negative peak or N1 and what we call positive peak or P1. This negative peak usually occur after 0.2 to 0.4 milliseconds and P1 occurring after 0.6 to 0.8 milliseconds. And the perpendicular distance between both is what we call the amplitude. Usually, as the stimulating current increase, the amplitude also will increase till we reach to a point of satisfaction. Okay, so this is the natural response to the electric stimulation. Here an example also for the interface or the panel of the software of the measuring software. As we can see here, notice here, as the electric current increase, there is N1 P1, N1 P1. As the current increase, the distance between N and P increase because the amplitude increase. And the relation between the stimulating current and the amplitude is normally linear relation like that. This is what we call the growth function. This is an excellent response. As the growth function is linear like that, as the configuration of the ECAP was negative and positive peak like that, this is the optimum ECAP that I can gain in and more or less straightforward surgery. This basic function or the ECAP, usually this is what they called ART. This is for middle or auditory response telemetry. For cochlear, they call it NRT, neural response telemetry. And for the advanced bionic, they call it NRI or neural response imaging. All of them measure the same physical principle of the ECAP. Now let's talk about electric ABR. Electric ABR is exactly like the ABR, and the electrodes or the leads can be fixed on the chin, behind the mastoid, on the forehead, either at the beginning of the surgery or after insertion of the device like that. Then we can give, instead of giving an auditory stimuli, we give a direct electrical stimulation, either at the level of the round window membrane or from the electrode array itself inside the cochlea, as we will see in the next slide. So after electrical stimulation, I can test not only the device, but I can test also the whole auditory pathway, the nerve, the brainstem, up to the nucleus in the brainstem. Okay, the most important advantage of ERP over the ECAP that the ECAP measure only the spinal population inside the cochlea or at the distal part of the auditory nerve. But here I can test the integrity of the auditory nerve itself. It's very important in questionable case about whether there is an auditory nerve fiber or not. In some cases of cochlear nerve deficiency, when I can see a proper cochlear nerve in the MRI, but the child or the patient gives some response on the play audiometry or on the pure tone audiometry. So here there is the debate: is there is an auditory fiber carried with the vestibular nerve or not? when I perform the electrically ABR, now I can be sure that there is definitely a neural fiber or auditory fiber if I have such response of the positive waves of the ABR. Okay. Actually, Mendel has what we called ANS or auditory nerve testing system. This auditory nerve testing system, usually it's an electrode array with only 3 electrodes that could be inserted through the round window inside the cochlea. And the function of this system is only to test the presence or absence of the response or of the auditory nerve. So it's a very valuable tool when I am not quite sure about the presence or absence of cochlear nerve, and what about its caliber, what about its function. So in such, especially in case of cochlear nerve deficiency, that might provide us with a very valuable information. Now let's talk about quietly less commonly applied electrophysiological testing. For example, the electrical stability reflex testing. Actually, electrical stability reflex testing can confirm the device function as well as the response of the whole auditory system, because it's include in its testing the central part. Also, it have a strong correlation with the comfortable level or the seal level, but it's being absent in a significant percentage of people, and normal ear function is necessary for the recording. Usually, the electrical stability reflex testing depend on my visual observation of the stapedial muscle contraction and of the stapes movement. Okay, so this test requires a preserved stapedial tendon, preserved stapes, stapedial crura, and the stapes itself, and also, as we can imagine, usually I have to preserve all this structure to obtain the stability reflex testing. Moreover, not all the equipment of all the manufacturers are available already for such testing. It's usually in the ART of middle. It may be a presence. It may be an available function. However, it's not such popular, and usually inside on our practical life and practical surgery, usually the ECAP and the impedance are such enough to test the electrophysiological testing of the device. Also, what we call spread of excitation. It provides an information about the selectivity of the neural excitation field around the electrode. What's about its phase? Here, as we can see here, when the electrode or upon electrical stimulation of the electrodes, the electrical field will propagate, as we can see here, to stimulate the spiral ganglia. Okay, the propagation of the electrical field may overlap between 2 electrodes, as we can see here. This is the propagated electrical field of one electrode. The red color represents the propagated electrical field of the other electrode, and here the orange area represents the area of overlap between both electrodes. So, upon stimulation of certain electrode, usually this overlap usually decrease as the electrode or the other electrode are away from the stimulated electrode. In other words, if I stimulate, for example, electrode number 1, then by logic, I can expect that when I give back, or when if I measure the voltage from the other electrode, I stimulate electrode number 1. It usually reduce electrical field that propagate to stimulate the spiral ganglion. Also, this propagation can be captured by the other electrode around the stimulated electrode. When I measured this captured voltage or captured field from the surrounding electrode, I can expect that the adjacent electrode might have high overlap. It might have relatively some sort of high voltage, and as the electrode move away from the stimulated electrode, the captured field should decrease, because logically the electrode number 12 is far away from the electrode number 1. So the captured electrical stimulation upon stimulation of number 1, it should be very minimal at electrode number 12. This occur in normal condition, but if I have what we call fold over, or if 2 electrodes are misplaced and their direction or their location are not in proper location, such a relation might be distorted. So if I have tested the spread of excitation and I found that, for example, electrode number 5 have a high overlap with electrode number 1. So I can expect that there is some sort of fold over of the electrode or misplacement of the electrode that make these two electrodes in relation or in contact to each other much more than in normal condition. And this is the idea about the spread of excitation. Also, the new cochlear software has utilized this idea or this principle to also predict the insertion of the electrode. As we insert the electrode array inside the cochlea, this function can give us an idea about the proper insertion and whether there's a full insertion or partial insertion of the electrode. But as I mentioned before, impedance and ECAP are the basics measurement, electrophysiological measurement that's usually carried out in all the cases by all manufacturers. Now let's talk about intraoperative imaging. Intraoperative imaging, it should be done as a routine whenever possible. Practically, it may be not necessary if the electrophysiological testing is optimum, because if the electrophysiological testing is optimum, I can predict that the electrode is in proper position. However, under certain circumstances, it's absolutely indicated, especially in inner ear malformation, characteristically in cases with wide cochlear aperture, to make sure that there is no misplacement of the electrode inside the IAC. Also, if the electrophysiological testing results are suboptimal, then I have to make sure that the electrode is in proper position. Intraoperative imaging modality includes mobile X-ray, fluoroscopy, intraoperative CT. Now let's talk about the fluoroscopy and the CT because they are now much more common than the mobile X-ray. Fluoroscopy, or what we call CR, usually it can be done after insertion of the electrode, and we can have such an image. As we can see here, there is a perfect curving of the electrode with electrode array having the turns of the cochlea. Then I can expect that this electrode is really inside the cochlea. It's not outside the cochlea. And if I have a more magnifying picture like that, I can even see, look here, this is the superior semicircular canal. If I make a vertical line like that, all the electrodes medial to that line, they are considered inside the cochlea because this line represents the side of the cochleostome or the round window. If I found some electrode lateral to that line, I can count it as outside the cochlea. Okay? Now let's talk about intraoperative CT. We have two types, intraoperative multi-detector CT and intraoperative cone beam CT. The intraoperative multi-detector CT are called aeromobile CT, and the cone beam CT are called the OR. Okay? This is the pictures of the multi-detector, and this is the picture of the OR cone beam, and this is an example of the image acquired by both. As we can see here, of course, as we all know, cone beam CT has the privilege of being of lower dose of radiation than the multi-detector CT. Number two, it may give us better spatial resolution regarding the pony structure, and it has less artifact, less metal artifacts. So this is a very excellent options in our cases, in case of CI. Okay, as we can see here, I can count the electrode properly well in relation to the multi-detector CT. This is another picture for other example. As you can see here, here's some much better spatial resolution than the classical multi-detector CT. And as we can see here, look here, this white line, this represents what we call metal artifact, because the electrodes are titanium. The electrodes are metal, so it can give some sort of metal artifact around it, which cannot be seen in the cone beam CT. And this is the privilege of the cone beam CT. However, the main disadvantage of the cone beam CT in relation to the multi-detector CT, which is usually not intraoperative, if we do it pre-operative or post-operative, because the cone beam CT requires the head to remain still or to remain fixed for acquire longer time than the multi-detector CT, and this can be difficult for a child because the child has to sit down, not to lie on a table, and not moving his head until the wall testing ends. This could be some sort difficult for children. So as a preoperative evaluation or as post-operative evaluation for children, multi-detector CT could provide us with a better information. However, intraoperatively, cone beam CT might be a better privilege if it available. Now, we will talk slightly about the post-operative imaging also to ascertain the site of the electrode. Also have the X-ray or the CT. X-ray, uh, we have a classical standard view which is called transorbital or stemmer view. As we can see here, there is the line of the skull. There is a very important line which is called orbitomeatal line. Our position is to make this orbitomeatal line perpendicular to the detector. So the child or the patient has to flex his neck slightly downward. If the source of the X-ray or if the view is anteroposterior, this is what we call the stemmer view. But the disadvantage of stemmer view is that it exposes the orbit to high dose radiation. So now we have what we call modified stemmer view. In the modified stemmer view, we have a postero-anterior position. This will lessen the radiation dose over the orbit and give us also proper position. So you have to flex the neck slightly downward to make the orbitomeatal line perpendicular to the detector. Also, the child or the patient has to rotate his head 45 degrees with the side to be tested closer to the detector than the other. As we can see here, I want to test the left side. So I make the child facing the detectors with slightly flexed his head, then turning his head 45 degrees towards the right. So he will bring his left ear or in the side of the implant closer to the detector. This gives us the best image or the best picture for evaluation. As we can see here, this is the picture. Let's take a magnified view. So as we can see here, look, this is a case with bilateral CI. As we can see here, both electrodes inside the cochlea can be evaluated. Now let's talk about postoperative CT. Of course, postoperative CT, as I have just mentioned, you can do it with cone beam or multi-detector, but the main disadvantage of cone beam is that you need your child to remain steady without moving the head or any movement of the head, because any movement of the head will create an artifact and make the imaging less perfect. So multi-detector CT as a pre or post-operative options could be much better than cone beam, especially for children for such a cause. As we can see here, we can see the electrodes is in the mastoid. This electrode is the basal turn of the cochlea. This is another picture, electrode inside the basal turn of the cochlea. You can use the DICOM material to create reconstructed transverse oblique long axis or cochlear view. As we can see here now, I can see the wall electrode inside the cochlea and I can calculate the wall or the number of the electrode inside the cochlea. Thank you for your attention.